would like to thank the organizing committee for giving this opportunity to talk on intraoperative dural tear. I'm Dr. Gautam Prasad from Patna, India. Dural tear. First of all, I would like to categorize that it's one of the most common adverse event that any spine surgeon encounters. Why is I say only adverse event? Because most of the time it doesn't turn into any complications. But at times we encounter complications, and this increases the morbidity, the stay, and rarely it becomes fatal also. So why it is significant? Intraoperative dural tear can lead to problems like it might further make the procedure difficult. Suppose we encounter the dural injury at the very beginning or in the middle of the procedure, then the further steps of discectomy, laminectomy, or deformity correction, or if we are doing a transpedicular decompression, all those things can become difficult. The bleeding can increase. And because the CSF leaks out, the CSF buffer around the neural structure that is lost, and hence the neural tissue can become more prone to injury. At times, the dural rent is large enough where the rootlets can bulge out and get caught with our instruments. So there is a chance of weakness or post-op paresthesia in such cases. During post-op period, the patient can complain of headache, meningitis symptoms. The patient will have delayed mobilization depending on how good or how bad the wound is. There can be persistent leakage or wound gape, which increases the stay and increases the expenditure of the patient. There can be patients who present to us late with symptoms like as leakage from the wound or pseudomeningocele, that is a swelling which is usually seen at this area. The risk factors associated with dural injury can be broadly categorized into the surgery or the procedure related and the surgeon, that is the technique and the learning curve. It's well established that cases of trauma or revision cases in which there is too much scar and one has to be extra careful, they have higher chance of dural injury. Cases of ossification of posterior longitudinal ligaments or ossification of ligamentum flavum, these are the cases which have adherent dura, in which many times even the dura is calcified or ossified. So these patients, they have invariably high chances of encountering a dural injury. There are cases which are complex surgeries in which corpectomy multiple level is being performed, or deformity correction or tumor. These are having higher chances of dural injury. Anterior surgery for higher cervical spine, especially the transoral surgery for odontectomy, these are associated with higher risk of having a dural injury because one is working at great depth, and if a dural injury occurs, then closure of the rent is at times tricky and might be very difficult. Having said so, even the commonest surgery that we do, that is lumbar decompression, at times we encounter a thin fibers or ligaments, fine ligaments, which are attached to the dura and the overlying ligamentum flavum. One of such ligament, which is usually seen at L5 S1, is called as attention terminal attachment ligament. And if we don't dissect it out before removing the flavum, then it can pull the dura along with it and cause dural rent. In cases where there is severe stenosis, especially long standing, the dura is thinned out, and that can lead to dural injury. Similarly, if the field is not good, there is a significant ooze, then these cases also one can encounter higher chances of dural injury. Now, various surgeon factors like the learning phase. So during initial phase, one is more prone to have complications. and that is true even with dural rent and dural injury. While learning newer instruments like high speed drills or burrs, one can in the initial phase cause more dural injury, especially if somebody is not accustomed or being trained under a experienced surgeon. Faulty techniques of cautery, like if one is not careful enough and puts the cautery in the interlaminar space, one can cause the burn of the dura and cause a rent in the dura. Similarly, if you don't dissect out the soft tissue well, the kerison or the disc rongers that we are using can cause dural injury. Poor handling of structures, especially in cases of complex deformity correction or in cases of revision surgeries, can cause dural injury. Excessive tractions or the bony spikes one leaves behind after performing laminectomy or medial facectomy can also encounter dural injury. Similarly, placement of screw, if it is too medial, breaches the medial wall, it can invariably rub against the root and the lateral edges of the dura can get injured. The most common complication that one comes across after a dural injury, especially if it is not well repaired or is undiagnosed, is headache. That occurs because of the decrease in CSF leading to tension headache. Wound leakage is another complication. Both of these lead to delayed mobilization. If the wound doesn't settle or the headache doesn't settle, there might be a need for re-exploration, which also increases the cost, stay, and there is a chance of having additional procedures. Rarely, the wound can get infected, which, if we are not lucky enough, can lead to meningitis and can increase the fatality of the surgical procedure. Based on various types as to how the dural tear is, we can classify it into, depending on the presentation, as pre-op diagnosis, intra-op diagnosed, and the post-op diagnosed dural tear. In pre-op diagnosed cases, usually seen in fracture cases, the fracture element, whether it is the bone lamina or the body, or in cases in which there is dislocation, there can be a dural rent with CSF oozing out, and we can track that on an MRI done pre-operatively. We can be extra careful in such cases, and we can plan whether the further procedures accordingly. Intraoperative dural tear. So once we come across the dural tear during surgery, we have to take corrective measures, and that we'll see how to proceed. And then comes the post-operative diagnosis. So these are the cases which have either gone undiagnosed, the intraoperative tear was undiagnosed, or the repair was not well watertight, or in cases where there was a bony spike seen, which was missed actually, and post-operatively during the post-op stay, the spike had led to a dural injury leading to CSF leakage. Now, this can lead to leakage of the CSF through the wound, or it can present as a pseudomeningocele, that is swelling at the operative site. Another way to classify it is based on the size. So if it is a small defect, it is a high tension defect, a high pressure gradient, so needs to be repaired. Larger defects, these are low pressure gradient, and we will see how to tackle it. Another way to classify is whether it is repairable or unrepairable, because this is what decides the further management of the dural tear. Now, once we come across a intraoperative dural injury, the next step that should come in our mind is two things. One, the actual procedure, and second, management of the dural injury. So management of dural injury can be in the form of stitch or dural adhesive glues or patch, a combination of one or more of this, or leave it alone with just a local fascia or muscle fat pad placed over the rent. And third thing that one should keep in mind is place a drain. Don't have a negative suction attached to it. just let it drain off by gravity. Coming to the procedure. So if the tear is small, then it is manageable, not causing a problem. Or if it is ventrally placed or laterally placed dural injury along the root sleeves, then these are something which cannot be repaired and is not we are not being able to repair it properly. Or the repair, it is ragged edges, totally unrepairable. Dural injury which has occurred preoperatively, associated with triple fragments or with misplaced screws. So these are the ones which we can just put in a patio over the rent, see to it that it doesn't ooze out significantly enough and it's not interfering with our other work. So we complete the procedure, whatever procedure is left. If it is not so, or is it causing a problem, or it happens at the beginning of surgery and it's a small repairable dural injury, then better to do the repair first and then do the rest of the procedure as we would have done otherwise. Once the dural injury is seen, check out if we need extra exposure. If need be, do it. Identify if there is only one or more than one injury. If it is repairable, have a watertight closure with a Vicryl or Prolene 40. Once the closure is achieved, check out with a Valsava maneuver. Supplement it with either a fibrin glue or dural patch or a fat muscle graft as and when necessary. So once there is a dural tear, check out if it is repairable or unrepairable. Repairable, go for primary closure and rest can be added on. If it is unrepairable, fibrin glue is an option. Have a watertight closure, or there we can use autologous muscle fat graft and have a watertight closure. Now in this, there's a small rent seen. This happened during the surgery and it was in the middle of the procedure. So a suture was taken as is seen on the picture on the right, and the rest of the procedure was completed. Now in another case, this is a post-traumatic thing. So in the left side, as we can see, there's a big rent which is seen, and here the edges are ragged. Doesn't seems like we'll be able to approximate. So what has been done is, as per the plan of the surgery, this thing was covered with patties. We have removed the anterior burst fragment, retropulse fragment, because of which the dura stretch over the dura has decreased, and then the edges became were approximated properly, and repair has been done, as has been seen in the extreme right picture. And this is a case which one can appreciate. So once the area is decompressed, the edges falls back and repair becomes easy. At times, they are significantly bigger rent in cases of ossified ligamentum flavum, in which at times even the dura is ossified. So these usually at the end of the surgery remains like a large defect and can't be closed. So just leave it, have a watertight closure, put in a drain, anti-gravity drain without any negative suction, and hope for the best. Post-op management. Complete bed rest and head low has to be followed till the wound heals or is healing well. Antibiotic prophylaxis, mobilization is delayed depending on the symptoms, and there is a questionable role of whether Diamox helps. So if the patient has too much of ooze, Diamox is given. Otherwise, you can hold on the temptation to add Diamox. So if the patient is bedridden, keep him supine, head low position. If the patient has no headache after 24 hours, tilt the bed by 30 degrees head high. If the patient has no headache, then one can be mobilized. But if the headache persists, then again we have to continue with the bed rest. Suppose on the day one, the patient, after 24 hours, the patient continues to have headache, then continue with the bed rest, check out for next 3 days. So after 3 days, if the wound is healing well, there is no leakage, there is no headache, patient to be mobilized. But if it is not so, the headache is significant, the wound is healing, is leaking significantly, then we need to take the patient to surgery, have a re-exploration, do the repair, and follow the same procedure. Unfortunately, at times we are not lucky enough and the leak persists. So these cases one should re-explore, Or other option is, if we already know that the rent was big enough, that is not or it was ventrally placed, which is not suturable enough, then have the patient in hospital for a longer time, have pressure bandage, regularly change the dressing, see to it that there is no secondary infection, keep the patient on higher antibiotics, and if situation doesn't help improve in next few days, have a proximal or distal CSF divergence. Many a times, patient have delayed presentation in the form of swelling, that is pseudomeningocele. So if it is symptomatic, no question about the management. One has to explore, suture it or repair it and put in a graft and hope for the best. Follow the same procedure. But if it is a large pseudomeningocele which is not causing any symptoms apart from the swelling, then we can have a regular follow-up and hope for the best. Now, tips to avoid injury. The first and foremost thing is training. That has to be unquestionable. That has to be very good. Cautery, as I said, check out that we are on the bones, not in the interlaminar space. Use patty wherever we are not able, wherever there is chances of having adherence. Use patties. Dissect out the neural structures well, and then use your kerosene and disc forceps. Identify if there is any adherence between the flavum and the dura. Be sure about your screw placement. At the end of doing a bony procedure, see to it that there are no bony spikes which have been left over. In cases of OPLL or OLF, use high speed drill, the regular drill that we usually use. And as we approach the dura in the depth, shift it to a diamond tip burr, because even if inventory we hit the dura with this, it won't cause injury. If the diamond tip burr won't cause any injury. If we have, then use ultrasonic bursts, Masonics. Always remember with revision surgeries, there are going to be scars around, so the exposure should be wide enough. One has to be extra careful. Don't do too much of retraction. Instead of having a blunt dissection, use a knife and cut it parallel to the neural structure so that we can have a clean dissection. And with all this, with time and with experience, one can avoid the chances of dura being injured. The final outcome. Now, if the patient has got a good dural repair, the outcome is almost same as the patient who doesn't have a dural injury. In unirreparable or uncomplicated, the outcome is almost same. But cases in which it gets complicated, meningitis or wound leakage, the outcome is not as good as other patients. So my take-home message would be, prevention is always better than cure. Intradural tear should be identified and repaired if possible. In unrepairable dural injury, use dural patch, glues, or muscle fat graft. Meticulous treatment of dural tear is the crux of favorable outcome. Always after the surgery, perform a Boltzova maneuver so that even if there is a missed dural injury, that gets recognized. And in delayed presentation cases, symptomatic dural tear has to be re-explored and managed with additional CSF diversion. Thank you very much.